of health in this country. And we have a live audience. They'll be asking some questions in a little short while. So, Chairman, KEMSA moving forward. You've been there 9 months. Yeah. The chairman over there said they're giving you a few more weeks. What if they come back and say, you know what, you guys haven't performed up to par?
Luckily, they won't say that. Yeah, they won't say that. There's a lot that we've been able to achieve. For us, when we came in, the issues, we found 3 issues, and which we've, one is people issue. Yeah, and that's the biggest in any organization, and change management is around people issue, to ensure that you have the right people for the right jobs, and that everybody, the culture within the organization is one where people can work. Secondly is about the image and the public image of the organization, and that's what really we've been working towards, to ensure that everybody, when they hear KEMSA, they don't think of corruption. Thirdly is our stakeholders. Different stakeholders, as we mentioned, the counties, the donors, the ministry. Counties is to ensure that we are able to deliver to them. That's why the order fill rate, we've been able to move it up from 49% to 62%, and currently almost 70%. The turnaround time, we're bringing it down. And even as you see, this, us being here in Kisumu, this is the RDC, started around 2016. Has not been actualized, and this board has been able to actualize it over a period of about 6 months. So, and once we finish the Kisumu, we'll be doing another one, a similar one in Mombasa, to improve on the turnaround time. And finally, is on technology, and that's really where we want to bring in the ERP. The ERP will be able to track and trace, will be able to really help us in appreciating and understanding everything that's within the organization. So those are some of the things that we've been able to achieve, and we expect that within another 3 months, which is now 1 year, as we achieve 1 year, we'll have achieved most of those things.
And tell me, okay, go ahead, yeah. Once you've done this region, you said Mombasa's next.
Next is Mombasa.
And then where?
From there, we'll need to have something around the northern part of the country, so that now we can cover the northern part. And actually, what we've even done with that regional distribution is we've changed the model of how we transport our products. So initially, there was a third parties lorries that had been hired to do the job fully, but now we've changed the model where KEMSA itself and the government agencies do about 60% of the transport, and we outsource about 40%. That has brought down the cost. Like last year was about 1 billion shillings. This year will be about 600 million. So there's a huge savings on that, and we expect even more because now essentially what we'll be doing is KEMSA will be able to do the transportation between the warehouses. And even the suppliers, instead of them taking the products to Nairobi, they will actually be able to bring the products directly to Kisumu, directly to Mombasa, ensuring that we do not have costs. We do not incur those transportation costs.
Okay, yeah. And what about what Senator Mandago was saying earlier on about expired medicines? That was one of the key negatives as well.
Yeah.
Jeff, allow me to add in one more question.
Go on.
You know, KEMSA also in the past, their products in terms of pricing were not competitive. So we also hope as Senate that the prices KEMSA are going to give to counties are going to be competitive, probably lower than the market rates because of the economies of scale in terms of their procurement. So, Chairman, you must speak to that.
Good point.
Actually, if I answer that first, in terms of the products, one of the reasons why sometimes most of our products are way cheaper than the market, actually about 32%, I think, cheaper. But one of the reasons why some of our products are not is the issue of supplier. If when a supplier is supplying to you but knows that they may not be paid for another 6 months, you see that they put in a margin, a financing margin. So now once we actually, with the funding that the ministry and the National Assembly got us from under the supplementary, some 2 billion, we'll be able now to pay off the suppliers and work towards a 90-day delivery payment plan for suppliers and commitment to pay.
And that way their prices will be...
That way they will actually bring us lower their prices. So for us, when we're looking at counties, the three things that we're able to guarantee and assure them: one is on the prices, bringing down the price. Two is on the quality, because we have our labs, and with our labs we're able to guarantee the quality of the products that we give to them. And finally is a credit. You see, when with us, we give counties up to about 180 days of credit, which they cannot get from the private market, because we understand that they don't fund themselves fully. They also do that from the government. So I think for us, what we are looking at is really engaging our stakeholders over this period to ensure that we serve them in the right way.
Absolutely. Yeah. Good point. All right, there's some questions from the floor, folks. Are you ready?
Yes, we are. But let me emphasize something.
Yes.
About the ERP that we are going to deploy at KEMSA.
And ERP again is
Enterprise Resource Planning. Is a system that manages. Many ERPs do not have the tendering component, but what we are getting now for KEMSA has a tendering component.
Okay.
Because what has been happening previously, that we have good staff, yes, but also the tenderpreneurs outside KEMSA take responsibility in influencing the procurement decisions. Now we have a component in the ERP of tendering, that we will no longer have tenderers bringing their envelopes and dropping them in a box where somebody can open, change, pluck off. I have had complaints where a page is plucked off, and for that reason, your tender document is nullified because it missed a page. Those issues, we are going to deal with them. Now we are going to get a tendering system whereby from wherever you are, put in your tender. Use AI analytics. Initial analysis happens. The people at KEMSA will only do verification of physical samples, but otherwise the system will be able to do much of the tendering process itself. Yeah.
And it'll be transparent that way.
A transparent system, visibility end to end. The vendor who has put in their tender, they are able to see the process. The institution can see the process. From where I sit, I can see the process.
And you'll be watching.
Yes.
Chairman, are you listening?
Yes.
All right, questions from the floor, please. Go ahead. Tell us who you are, who you represent, and what's your question?
My name is Beatrice Amondi. I'm from Jiwo Mwanadada Foundation. Jiwo is a Luo word meaning to exhort. I'd like also to commend you on the good job you're doing, Madam CS, and also our governor. I'm very delighted that you're supporting the President's agenda on health. Thank you very much. So to my question, you have stated the problem, Madam CS. We need health financing. I was just wondering if you have any laid out solution on how to achieve this. Secondly, on the deduction on the income on the 2.7%,
275.
2.75%. For the longest time, the formal sector has carried the informal on their backs. So I'm just wondering if you have any strategy on how to go about this with the informal sector. Also, to our governor, I have a question for you. Using your words, you stated that health is a very fundamental need. And in the CIDP that you presented, I did not see any allocation for the same Yago dispensary, which has not been operational for the longest. Do you have any plan to revamp it?
Good. Madam CS, you first.
Yes. Thank you. Healthcare financing is actually the engine to achieving universal health coverage. So what we have done, and that is why we brought in the new laws, that one, we are re-engineering our healthcare. Previously, we have been more fixated on curative services. Yet we know very well that prevention is better than cure. Study has it that you spend less in prevention than you spend in curing. That's why we are refocusing on the primary healthcare. That is one way of re-engineering our health spending, that now we spend less. Just as Professor Anyang said, we now promote healthcare. We educate people about living a healthy lifestyle so that then you don't get sick. Therefore, we don't spend. But in terms of collection, now the 2.75%, you rightfully say that the informal sector has not been compliant. That even the current NHIF, it was said that NHIF is mandatory, but that was not enforceable. So in the current law, in the regulations, we have put in mechanisms of enforcing people to pay their social health authority. And one is that for those who can't pay, won't pay, they have no income. The national government, the government, is putting in a subsidy to pay for them their social health authority. So already there's a population that the national government is going to take care of at 300 shillings per person per month for their insurance. We have the other one that is the employed, and that is not a big issue because then they interact with government on a monthly basis. So then the deduction is at payroll. We have the informal, where the issue is. And being informal doesn't necessarily mean that one does not have an income. We have people who are in the informal sector, yet they earn millions and millions of shillings. So we have put in a mechanism that at the point that you interact with a government service, then you are required to pay for your social health authority. And we are saying that for the informal, we will require that you pay your annual premium, not monthly, because the government has no other way of interacting with you as an informal person except that time that you are coming for a service. For those who, and you know, the informal income is not uniform, is not consistent. There's somebody who is in the business of maybe construction. Today they'll have 60,000 shillings. The next month they'll make 10,000. So we have also made a provision that you pay once when you have the income. But those who may not have it, but they are likely to get, we have also put in mechanism for premium financing. That through like Hustler Fund, you can borrow money and pay for your social health authority. We have put in mechanisms from the private sector where they are able now to sell premiums, that you can borrow money and pay for your premiums. We have also put in some aggregation mechanisms, like people who belong to SACCOs. SACCOs can be able to advance them money to pay through for their social health authority. So the mechanisms are there. Now it is a matter of enforcement. But I want to speak to Kenyans and say, really, we have to change the culture. Let's not wait to be chased around to pay that is of value to ourselves. Yeah. So let's just get into the culture of being able to pay upfront. And Jeff, I know that you are well traveled. You know, out there, people don't have discussions about paying for their social.
There's no discussion.
There's no discussion. You got to pay, you got to pay. Yeah. So as a country, let's now get to that level where we appreciate the upfront payment of your premiums. Yeah.
Point.
Let me
Governor,
just,
yeah, the dispensary.
Yeah, before I go to the dispensary, Dr. Ganda is here. Dr. Ganda is the Minister for Health. So you can all readily solve your problem. And by the way, the CIDP does not contain everything. It's a policy document. So details like dispensaries and so on, you can. Secondly, if you live in Kisumu County, you realize that the issue of the informal sector, or those who are not formalized, we have covered through a common health insurance scheme called Marwa, which means hours. We have a health insurance scheme, which hours. If you live here and you're not formally employed and whatnot, nothing stops you buying NHIF, by the way. But we have an alternative here called Marwa, which you are free to join and cover your health insurance. The other thing that I wanted to say, which Susan covered earlier, is the issue of retaining revenue at the point of earning. Greg, what do you call it? Facility Improvement Fund.
Yes.
We have been practicing for a very long time in Kisumu County. Because we realize that if you have Facility Improvement Fund, it's easier for Dr. Ganda, for example, to make sure that down there in the health center or in the dispensary and so on, they can manage themselves. The only problem is that those small health facilities do not have the capacity or capability of employing technical people like clerks and accountants and so on. So that's something that we must grapple with when we are dealing with facility improvement funds, so that you don't give people responsibility without the technical ability to manage it.
All right. Question from the floor. You have a mic? Do you have a mic? Go ahead. Tell us who you are, who you represent.
Thank you. My name is Maurice Owaka. I represent Senator for Kisumu County, Professor Tom Ojenda, who has just landed from outside. And he
just landed?
Yeah. No, to Kenya.
Is that
Kenya. He's
necessary
back
for
to
us?
Kenya, but now he's in Nairobi. Yeah, he's back to Kenya. So he told me to extend my greetings to the panelists and also register his apology. First, I want just also to congratulate and also pass much accolades to Waziri for the good work, because here I am. I'm a signatory to petition that was that is already at the Senate, presented by Kisumu County Senator, so that Jaramogi can be elevated to level 6. Again, I want also now, my question will go straight to the our beloved governor, who has just mentioned a scheme, which is Marwa scheme. Governor has explained it well that it does not affect the other social insurance fund scheme that is yet to be implemented. Now, my question to the governor: what are the requirements, set requirements for the enrollment for the scheme? Then again, what are the sources of the support for the scheme? We understand that for the other social insurance, health insurance fund, the sources, you find that you'll be deducted 2.75%. Now, for Marwa scheme, I want to know what is the source of the funding. Again, another question.
By the way, how many questions do you have?
Up to only one. Only one.
This is another question now.
Yeah, another question. Recently, Kisumu County under Health Department signed a private firm to assist in distribution of drugs and other pharmaceutical commodities by use of drone. This has always piled pressure. Are we going to focus on the distribution of the commodities, or we are going to pay KEMSA so that we can address the issue of availability of the commodities in the facilities? You'll realize that in most cases we have shortages of drugs and other pharmaceutical commodities, even at the level 1 facilities. Thank you.
Chairman, you take that second part, then Governor will come back to you, okay?
Yeah. I think that's for Governor. He's talking about whether they'll pay KEMSA.
Yes.
Of course, I would want to be paid.
All right, Governor.
He's jumbled, actually, that fellow. I don't quite understand what he's asking. But the point is, zipline cannot be confused with normal distribution of commodities in health facilities. Zipline is a facility that helps us distribute commodities, either health facility or commodities or otherwise, to remote areas or where there's urgency to do so. For example, during COVID, if you want to transfer blood from Jaramogi to, let's say, Papunditi Hospital, and that blood is needed for surgery instantly, if you put it in a car, it will arrive there too late. If you give it zipline, it will get there in 3 minutes. So zipline is a facility that helps us save time for distributing health commodities efficiently. It's not a replacement for distribution of commodities by KEMSA. So you should have done your homework properly.
Yes, but
that gentleman has raised an issue which I think needs to be addressed. That here we are as KEMSA, we are saying that our order fill rate is now at 70%.
Right.
So what KEMSA will take to the county is 70%. But there's something that needs to be done to ensure that that 70% translates to 70% availability to the patient. And I think that is the clarity that the gentleman is seeking. That as we say KEMSA is at 70%,
right,
are wananchi receiving 70% or they are receiving 10 or 20%? There's some supply chain issues that need to be streamlined by the counties. And that zip line is one of the solutions, I believe, to ensure that then the medicine reaches them.
Reaches the people. Okay,
Yeah.
good. Yeah? Is your question short?
Yes.
You sure?
Somebody there.
Go ahead.
There's
And then you're next, okay?
Thank you. My name is Rafael Chimera, Senator from Kwale County. Mine is very simple and clear. What is KEMSA doing, strategically speaking, to ensure this 3.2 billion is settled in good time? Thank you.
Chairman.
Thank you. Actually, when we came in, what we found is that a lot already was about 3.6 billion. And we were able to bring it down to about 2.2 billion, mostly by engagement with the counties. What then also happened is that when the order fill rate was very low, counties also did not have a real incentive to pay KEMSA's debt, because if it's at 30% and even if they pay you, they still have to go look for another 70% elsewhere. So there was no real incentive for that. So we've now at the levels we are at, 60 going towards 70%, counties are getting a lot more for KEMSA, and then and for that reason they are willing to pay. Secondly, we have about 4 counties only who have bills older than about 210 days, which is about 7 months. So after 210 days, we are not able to supply to those counties. So all the other counties, about 43 of them, have current bills. So when we were looking for this new funding, which was more around the recapitalization for KEMSA, we were looking for it because we felt that the 3 billion that is owed to us by counties is more like a fixed debt that will never change. Because today this county comes and orders, pays you 50 million that they owe you, but tomorrow they come and make an order of 60 million. So you cannot refuse them because they don't have a debt with you. So that's the reason why this 3 billion will always be fixed. But for us, what we are saying is we want it to be new debt and not old debt.
Is Kwale County among them?
Kwale is good.
Okay.
Kwale is good.
Okay. Sir?
Okay, my name is Job Ochieng from Tilapia Youth Group, working with Youth Alive Kenya. I have 2 quick questions. Question number 1 is for our able governor. I want to appreciate what the county government is doing in terms of issues of health. But I have one quick question to them. When they are always referring the patient from various sub-counties to the referral centers, most of the people are dying at the reception because in each and every referral center, they don't have data. So it forces people, those who are working at the referral center, to take the data, the bio problems for the patient. What are they doing to support that issue? Because most of the people are dying at the OP. Most people are dying for the OP. That is question number 1. Number 2, I want to ask the KEMSA. We have 2 issues. Number 1 is that they have struggled to defend the issue of procurement at the national level. But at the delivery, we have so many, at the dispensaries and the hospitals, we don't have drugs because those they are giving drugs are disappearing with the drugs. They are disappearing with the drugs. What are the mechanics that they have used to prevent that issue? Then lastly is the Waziri. The Waziri is doing very well, and I really like what she's doing. Because in Vihiga, which she's coming from, she is doing a lot in terms of sensitization. What she's going to do to Kisumu County to sensitize the Kisumu County, especially on social health insurance, because Kisumu County is suffering on issues of polygamy.
Governor, So, Senator, you were in the unique position of being governor and now senator. People dying at the reception area of hospitals. That was the first point.
Thank you very much, Jeff. I want to believe now with the rollout of the Social Health Insurance Fund and the universal health coverage, where government is putting a lot of focus in ensuring that drugs and services at level 1, level 2, level 3 are available, and with the support of counties in making sure that we also have human resource, I think that will be a thing of the past. However, in terms of referral, Jeff, counties will also have to put in some resources in terms of ambulatory services, so that when referrals are made from a facility, then the patient doesn't have to go home again, you know, to look for means to move to the next referral facility. And finally, Jeff, I think Chairman forgot that national government also owes KEMSA. I don't know what plans do you have to make sure you recover the debt from the cabinet secretary.
Well, you know, if everybody who goes to a hospital or a health center dies at the reception, then we'll all be dead. Sure. We have seen a lot of people here I've met in hospitals at the reception, being booked in, who are alive. And you also talked about data. I don't know what you mean by data, but you should have come with some data too, to show us how many. You can't talk about data when you yourself are nothing.
Maybe he's polygamous.
I mean, if you want to be polygamous, it's okay, go ahead, be polygamous.
Okay, over here in the middle, yeah? Short and sweet, right?
Thank you very much. My name is Obungu Sospita Wich, and I represent the Sufuria Revolution movement. And I'm also a member of the civil society organization. First, allow me to congratulate our able governor, Professor Peter Nyang'nyong'o, for laying a very proper foundation that is handling health here in Kisumu. We seriously thank him for that. Second, I want to ask the CS for health a very good question.
One question, right?
I have two.
Keep it one, please.
Are there any legal provisions for other forms of partnership in the KEMSA Act? That is one. Two.
Jeff, you give up.
What assurance is she giving us that there will no longer be corruption at the KEMSA as a department? And lastly,
I thought, when there two, listen, stop, okay? Madam CS, please answer the question. My friend, please. Everyone wants to ask questions. We'll be here till tomorrow.
It's not a question.
No, sit. Madam CS.
Thank you. The chair already responded to that question. What we are doing in terms of governance, those are meant to ensure that we do not have the issues of the past. And I would like Kenyans to look at KEMSA as version 3 now. Yes, so that we are not just looking at the history. We know where we have come from. We have put in measures to be even where we are at. For KEMSA even to agree to be on a live TV, that's progress. We have a plan into the future. The board here was carefully selected. And Jeff, one of the people in that board is the person who gave me an opportunity to be who I am today, Dr. Jane Masiga, who sits right here.
Oh.
She believed in me 18 years ago and gave me an opportunity to be a warehouse operations officer at MEDS. And when I went to her and told her there's a problem in procurement and I think I can solve it, she put me in procurement as the manager. And since that day, I've been solving procurement issues. We know what to do. Give us a chance. But again, we have made deliberate efforts to use technology. Because human beings are human beings. And from where I sit, we have cleaned KEMSA inside well enough. We now have a system in place. And moving forward, anybody who tries to corrupt KEMSA, I believe will be from outside and will not spare them. We'll always display a list of shame for the people who want to destroy KEMSA. In terms of partnership, KEMSA works very closely with partners. The chair spoke about USAID. We work very closely with the USAID. Gavi, we work very closely. And other partners, we work very closely to provide services. My friend, I don't come from Vihiga. I come from Trans Nzoia. But what we have done in the new law, which I believe you are alluding to, previously, men would only declare one wife and cover one wife, yet they are polygamous. So when the second, the third, and the unknown number N wife gets sick, there's nobody to take care of them. Under these new regulations, we are saying declare, pay for them, so that they are all taken care of.
Can I just add something?
Yes, sir.
You see, we have to congratulate Susan for putting in place a good board and a good CEO. Because if you don't have a good CEO and a good board, you are doomed in any organization. When I became Minister for Medical Services, KEMSA was in a mess. Worse mess than Susan's mess. What I did really was get rid of the old board, the old CEO, and I put a young man as a CEO called Dr. Munyu. And a new board under the chairman of Solomon Karanja, who used to be the registrar at the university.
Right.
And all these things that are now being done now, we did then, ERP and so on. But when Munyu left, when a new board came there, which had other intentions, the fish started rot from the top. So we hope that what Susan is doing now in the ministry, we will not have a board and another CEO when she has left, which will go into regression alone, because it's a pity really that we have to go through these cycles where an institution is reformed, is going on well, then management comes with new intentions and turns it backwards. And I must, where's Mulwa? Please stand. This young man has just won a prize for good governance. He's the CEO of KEMSA. He's won a prize for good governance. No wonder that KEMSA is being managed well. You are another Munyu. And we would like the Mulwas and the Munyus to manage government institutions transparently and accountably and capably. After all, you are given a government institution to run, and you begin stealing for it because you want to make wealth. When you die, who will use that wealth? You will go up there and you go to that very hot place. Please try to avoid that.
Questions aside. Ladies, any ladies? Go.
Thank you. Good evening, everybody.
Louder, please.
I'm Joy Muyonga. I'm a doctor. I'm a pediatrician. Thank you very much, Madam Waziri, for Madam CS, for everything you've done for SHIF. We would like to just know, my biggest problem is sickle cell disease in Kisumu. So do we have a package for the sickle cell patients? And going forward, do we even have a package for bone marrow transplant? Thank you.
Jeff, we do. Earlier on, I spoke about congenital diseases. One of them is sickle cell. If you look at the package weight, when the gazettement is done, go to the annexes. You'll see the extent of the package, and sickle cell is well covered, and it is covered under the emergency chronic and critical illness fund, including the bone marrow transplant.
Also.
Yes.
In the back there, yep. Go ahead.
Put on the mic, man.
Mic's not working. Let's get someone else while we fix that mic. Here in the front. Go ahead, lady.
Thank you very much. My name is Esther Raila, presenting through this event. As a young, vibrant entrepreneur, my question goes to KEMSA chairman. What other operational and business provisions are there under the KEMSA Act for the common mwananchi? Thank you.
Yes.
I think for what we are saying in terms of KEMSA is that it's open for business like any other, and as long as the business is done right, and for the youth and women also, actually for AGPO, our target is the 30%, and actually even with the last tenders we achieved over 30%, and also we'll be over the once we finish, we start the e-procurement module within our ERP, which should be this coming month. We'll also start pre-qualifying companies for tenders and works within KEMSA. So again, those are open. If you go to the KEMSA website, it has an area on tenders, which is open. Any tender that you see from KEMSA, it's on the newspaper, and also on in that section of the website, you can be able to access. And as the CS said, with the new procurement module, the e-procurement, you'll actually be able to tender for all these jobs without any human interference.
Let's go this side. Go on, yeah. Lady in the, yeah, with the mic.
Thank you so much. My name is Mariam Abdallah. I'm a resident of Kisumu County, and thank you so much to the panelists. My question goes to the CS. How is the transition going to look like, given that we have pending bills of NHIF in some of the hospitals? Then number two, to our Governor, Nyong'o, the issue of Facility Improvement Fund. We all know that it's low. What are some of the measures that your county is going to put in place to ensure that we improve the Facility Improvement Fund, especially in the rural areas? Thank you.
All right.
Jeff, we did gazette a transitional committee of 9 people that is looking into how we transition from NHIF to SHA. They have already developed a roadmap. They have already developed guidelines, and we are aware we owe facilities 29 billion shillings. Equally, the NHIF is owed another 29 billion by other agencies. So we are looking at collecting what we are owed, then pay. But for the comfort of facilities, SHA is going to inherit the debts, the assets, and everything that belongs to NHIF. So if that is not paid during the transition period, it will be taken over by SHA. And if the what is owed is reconciled, remember we have people who are putting in fictitious claims.
Correct.
So if it is reconciled and it is agreed on that is a true representation of what is owed, it will be paid by SHA. So there need not to be anxiety to the facilities that we owe, because they'll be taken care of by SHA. Yeah.
Okay. Governor.
Jeff, can I ask a favor?
Go on.
Can I ask my Minister for Health, Greg Ganda, to answer that lady on Facility Improvement Fund and the problems therein? Because the governor doesn't always know everything. Can you get a mic?
I think I'll refer him to your State of County address, that if you looked at the improvement of FIF in primary care facilities, that is where we had the highest increase. We had facilities which increased their revenues by up to 10-fold and 8-fold in the lower facilities. So there's much improvement in the lower facilities. And if you looked at, again, our strategy for this financial year, we are improving primary care facilities, at least one per ward in this financial year. Now, when you improve the facilities, you improve the equipment, and you improve the outlook, then that is another way of improving the Facility Improvement Fund. So go to the website, look at it, and you'll see the different facilities and how they improve their Facility Improvement Fund. Thank you.
What about the dispensary, the lady who talked about earlier on, which has been closed for many years?
That's another thing. There were so many dispensaries which were started but never completed. And so what we decided is that you don't need to have 100 poor facilities. It is better to have 20 well-equipped and well-resourced facilities running. And so what we are doing is we are completing them one by one. When we complete a facility, we bring in the human resource plus the equipment. So you go stage by stage to make sure that they're all operationalized. Thank you.
Thank you. Yes, sir.
You've forgotten the young man whose mic.
Oh, he's still back. Did he get a mic? Did he get a mic? Okay, we'll come to you. Sir, in the glasses.
Okay, good evening. I'm Ben Okoth, a serious resident of Kisumu and the great continent of Europe that's led by Governor Nyong'o. My question goes to CS. What is your government doing to ensure a robust health system and access to healthcare? The last question, health being an elephant in the house, is it possible you make NHF unlimited so that one does not need to choose an outpatient facility, but just an active card to access health services in the country, since the public hospitals are serving one government? Thank you.
Thank you. Good question.
Yes. The whole evening we've been talking about what the ministry is doing, what the national government is doing to ensure that services are available. I like the last question that you have asked. Under the Social Health Authority, we have 3 funds. One is the Primary Health Care Fund, which is non-contributory. You are not expected to contribute as a Kenyan to that fund. It is being provided by Exchequer to ensure that level 1, which is the community level of services, level 2, the dispensary, and level 3 is equipped, has HRH, and has commodities to take care of you. All you need to provide is your SHA registration. And we do not have physical cards. We have digital identification. So on registration, you'll be given a digital number, which is ideally your ID card number. That is what you'll be expected to produce at each and every level of service. At the primary healthcare, which is level 2, 3, you're not expected to pay anything, but you'll be able to access, you must have your card. The secondary level, which is now 4, 5, is where we have the SHIF. That is where you are required to make a contribution, that you must be paid up on your contribution, then access services. And at the tertiary level is where we have the emergency, chronic, and critical illness fund. All these good things that we are talking about, Jeff, they are not going to be possible if we do not register and pay up for our social health insurance. So since Kenyans, we want to have the good health care that we want, then let us be patriotic enough to pay our social health insurance fund, 2.75% of your income. Yeah.
Very good. All right. There's a lady in there with glasses. Is it a short question? Is it a short question? She's not going to say it.
My name is Caroline Ayugi. I'm a travel consultant. My question goes to Waziri. As we are all aware that we have patients, students who are stranded in India or who are under comprehensive cover, under Edu Afia, and Edu Afia was scrapped on 31st December. So my question goes to you, Waziri. What is the solution and what communication is there towards the students who are stranded outside the country?
Good.
Thank you. One of the problems that we had under NHIF is the different parallel schemes. We had Edu Afia that was covering a student. We had Linda Mama that is covering mamas who are expectant. We had the one that was covering the vulnerable. So what we have done under the social health insurance is to have a cover that covers the household. That now we don't just to linda mama, but tunalinda jamii. We linda the mzee, we linda the child, we linda the mama under the social health authority. Under this social health authority, since we are covering the household, the student who was under Edu Afia is now covered under the household. So now we have a cover that takes care of the whole household. Whether you are the mother, you are the baba, or you are the mama, you are all covered that. We have a problem. We did give notice that Edu Afia was coming to an end. And NHIF was a service provider. Ministry of Health contracted NHIF to provide EduAfya. So when a service provider says, I am no longer able to provide, Ministry of Education, sorry. When a service provider tells you that I am no longer able to provide this service, then you have to look for an alternative to that service. I am in discussion with my colleague, Ezekiel Machogu, and he confirmed to me that they have contacted the families in terms of giving them an alternative to what NHIF was providing. And I hope that is resolved very soon, so that then the bigger cover that we have provided kicks in. Yeah.
You know what? Good thing is these people are asking the right questions.
Yes.
It's fantastic that you do this, and you should continue asking the questions. Not tonight, though, because we're running out of time. All right, but thank you. Thank you for your contribution. Makofi, everybody. Well done. We're now going to get some closing thoughts on going forward, and I'd like to start with Senator Jackson Mandago, all the way in the corner there. Closing thoughts going forward.
Thank you, Jeff, but let me ask for your indulgence. That young man has switched positions, I think, 3 times just to make sure.
Is that right?
I
you insist on this question.
Let him ask, and he can direct it to me.
Governor.
Thank you, Senator Mandago. So,
what's wrong with your mic, sir? Just put it in your mouth, man.
Mic is on. Mic is on.
Yeah.
My name is Yusuf Bakari Bayan, representing National Industrial Training Authority, NITA, hereby school. So my question goes to the Madam Susan Nakhumicha, or the KEMSA board. So, based on KEMSA's expanding missions, are there any changes you would recommend to deal with mission creep?
To deal with what?
Mission creep. Mission creep.
What's that?
The
What's
English
that?
in Kisumu is too heavy
It's sounding like the prayer that we had last, you remember the prayer?
Yes.
From Homa Bay?
Yes.
I can't get
Raphael, what was his name? Yes. All right, Governor. Senator, you've indulged him.
Yes.
Let's get some closing thoughts.
Jeff, in closing remarks, one as Senate Health Committee and as Senate, we promise Kenyans to do our oversight, and just as the CS will be monitoring the KEMSA board, we as Senate will also be oversighting the ministry together with KEMSA to ensure all that they have played to Kenyans in terms of commitment, they should be able to meet. Secondly, Jeff, we are looking forward to KEMSA opening up all the 8 regional distribution centers just to create that efficiency across the country as we roll out UHC. And I want to ask Kenyans and appeal to all of us, let us support the rollout of universal health coverage by registering and willing to pay. We cannot get services without paying for it. Thank you very much, Jeff.
Absolutely. Yes. Dr. Robert Pukosi.
Thank you, Jeff. And just on my closing remarks, I want to recognize my colleagues from the Health Committee who accompanied me here, Dr. Nyekal, Honorable Joshua Oron, and Honorable Martin Owino, who are here with us. And what I want to say is that the Committee of Health will continue making sure that we oversight KEMSA and the ministry to make sure that the services they are offering to Kenyans. You know, the law, the KEMSA Act, talks that KEMSA is the first call in terms of provision for public health facilities. And therefore, they have a responsibility to make sure that they provide drugs, medicines, and let's say health products and technology to all Kenyans, wherever they are, at an affordable cost and cost effective. The issue of corruption should be a thing of the past within KEMSA, and they should be able to now have a new image that can be able to at least give them a honor. And I want to thank the chair and the CEO for the good work, together with the board, for the good work they are doing, and encourage them to continue on that path, that moving forward, you'll be able to at least do the right things. Lastly, I want to ask the doctors, with this shift,
one of the pediatricians talked about bone marrow transplant and management of sickle cell patients. This country, we don't do bone marrow transplant. But I think it's a high time that doctors in this country are able to put up infrastructure to do bone marrow transplant instead of sending patients to India and other countries. Thank you.
First, I think there are just two questions that were not answered. The first one is on mission drift. KEMSA is not, we are focused on actually our function. We have a KEMSA Act, which defines our role, and we stick with that. Our focus right now is on what we call the essential, the VTAs. Yeah. And then in terms of the tracing the items from KEMSA, why we even request or urge counties to order from KEMSA is because the drugs from KEMSA and the health products and technologies that come from KEMSA are actually labeled and marked KEMSA, and that means that they're not easily lost even when they get to the facilities. And then I'd like, before I finish, to recognize my board, the board members who are here. We have Dr. Jane Masiga, we have Julius Bitok, we have Mary Awino, and we have Honorable Bet. So Hezbon Omolo is not with us, but he's also a member of the board and is from here. I think for us as KEMSA, the commitment that we'd want to give, one is that we will clean the name of KEMSA. And that is our key agenda, to ensure that when people hear KEMSA, they hear of a partner in health and an organization that is dependable to them. Secondly, is on the order fill rate. Our commitment is to bring that order fill rate to 100%. It will take a lot of effort. It will take each one of us from different stakeholders, from the KEMSA itself, from our clients, the counties, as well as different stakeholders that we have. And finally, is on a turnaround time in being able to deliver to the counties. And that's why we have opened and launched this RDC. We'll do this one. We'll open the one in Mombasa to cover the coastal counties, and then we'll set up the others that are necessary at that point. But to ensure that we're able to deliver the medicine to the counties and to the last mile in the shortest time possible.
Good one. Yeah. Governor, Professor Anyang Nyong'o.
Thank you very much, Jeff, for facilitating this discussion this evening, which is very important. But I want to appeal to the audience that health begins with you.
Good.
Don't wait until you are acquiring medicine. Try and engage in preventive health care by eating right, doing the right things that can keep you away from drugs. Second, which is again our responsibility as Kenyans, is I think through the community health workers, for example, we are trying to teach households that it is important to know your state of health. For example, go for a checkup. The First Lady in Kisumu County is leading a team of First Ladies that is doing screening for women and girls for cervical cancer and breast cancer, but also encouraging young boys and young girls and the parents for a test of what we call human papilloma virus, which leads to this cancer, cervical cancer. Let us take these preventive measures very seriously, because they will then reduce our cost of health or buying medicine when we could prevent it. Prevention, as we learned. Prevention, as we learned in primary school. I don't know what kind of school you go to, but prevention is better than cure. I'm a civil.
Yes.
Thank you very much, Jeff.
Madam CS, you get the last word.
Thank you. Thank you very much. Let me first thank His Excellency the Governor for hosting us in this lakeside city. We are happy we've been well taken care of. I want to commit to Kenyans that in terms of delivering universal health coverage, we are on the right trajectory. under the 4 pillars of health commodity security, which we are fixing, and that's the reason we are here today. The second pillar is on technology, which we are also fixing, and we have been demonstrating in our discussions that we are fixing that. And in the foreseeable future, probably in about 10 months, we shall have all health facilities connected, starting from the level 1. And Kenyans have seen level 1 is the community health promoters. They have kits, they have gadgets, they are ready to provide services. The other pillar is on human resource for health. I want to acknowledge that we are not yet there, but we are working on it. We know what to do. For us to be able to address the issue of human resource for health, which is a critical pillar of universal health coverage, we must have financing. And that is our other pillar under universal health coverage, which we want to achieve through the social health authority. So I want to tell Kenyans that we are on the right trajectory. We know what we are doing. We have a plan for each of the 4 pillars to ensure that health services are brought to the closest, to the people, and they should not suffer financial loss while accessing services. But also to implore on you, Governor Nyang has said it is your responsibility. So as we roll out the regulations as they get gazetted, please let us register for Social Health Authority. We have made registration easy. 1, you can self-register yourself through your mobile phone. If you have a difficulty, you go to your nearest Huduma center. They'll be able to register you. We have contracted Safaricom. If you have a difficulty, go to any M-Pesa agent. They will be able to register you. If you have a difficulty, go to any NHIF office, which now we are rebranded to SHA. They will be able to register you. So let's register ourselves and let us pay up for our social health insurance. Afya yako ni jukumu lako, na afya yenyu ni jukumu langu. And I want to commit that we are going to optimize the resources that we shall receive to ensure that we deliver health services to Kenyans. Thank you, Jeff.
All right. Another round of applause for all our guests, please. Yeah. Madam CS, Chairman, Dr. Ari, Governor, Senator, thank you so much. You guys have been fantastic. Great conversation, and that conversation will keep going on. And like you said, CS, it's going to take all hands on deck, right? One hand can't clap on its own. All hands on deck. Well done. I hope you guys have had a good time. Thanks so much for being a part of this audience. Give yourselves another round of applause. Thank you very much. Good job, everybody. Good job. And thank you for joining us tonight. Thank you, Governor, for hosting us in Kisumu City, where we landed. You just don't arrive. You land. And remember, if it's Wednesday, it's all about those 3 letters on the keyboard that follow each other. JKL. Thanks so much for being a part of JKL on the road this week in Kisumu. Next week, you never know. Look out. Stay tuned. We'll see you then. Good night. Good luck. God bless this lovely county of Kisumu. Thank you very much.
Thank you.